Hey there, future nurses. In this voiceover, we're diving deep into respiratory nursing, covering everything from assessment to diseases and critical care. So get comfy, grab your notes, and let's make sense of the breath of life. Respiratory assessment and basics. Let's start with a quick review of respiratory anatomy. The nasopharynx connects the nose to the back of the throat. It's where you'll find the eustachian tubes. The oropharynx lies just behind the mouth, and it's home to those palatine tonsils most of us had removed as kids. Now when we talk about acid-base balance, here's the simple breakdown. Respiratory acidosis equals not breathing enough, gives CO builds up, gives low pH. Respiratory alkalosis equals breathing too fast, gives blowing off too much CO. Metabolic acidosis equals caused by things like diarrhea or kidney disease. Metabolic alkalosis equals think vomiting or antacid overdose. Tip: always start your respiratory assessment by asking, "What's up?" That stands for, where is it? How does it feel? What makes it better or worse? When did it start? How bad is it? What other symptoms are happening? Inspection, palpation, percussion, auscultation. Look for symmetry of chest movement, accessory muscle use, color of skin and lips, chest shape, breath sounds. Listen for crackles, wheezes, stridor, and rubs, and always compare bilaterally. When percussing, normal lung sound resonant, dull equals fluid or mass, hyperresonant equals trapped air like in emphysema, flat equals over bones or large effusions. Lab tests and diagnostics. CBC. Low hemoglobin means less oxygen carrying capacity. ABGs. Pay attention to pH, POCOs, and POW. If POW is under 50 or POCOs is over 50, that's an emergency. D-dimer helps detect pulmonary embolism. Sputum cultures should be collected in the morning, before breakfast. Chest X-rays and CTs help identify pneumonia, tumors, and effusions. Pulmonary function tests tell us how well the lungs are working. Therapeutic measures teach pursed lip breathing and diaphragmatic breathing. Use incentive spirometers post-op to prevent atelectasis. For positioning, use Fowler's or tripod positions to help with breathing. Deliver oxygen via nasal cannula, simple masks, or non-breather, depending on how much oxygen the patient needs. Watch for oxygen toxicity if FiO is too high for too long. Use chest physiotherapy, PEP devices, or even an oscillation vest to clear secretions. Common upper respiratory disorders. Let's start with something you've definitely seen: epistaxis or nosebleeds. Treat with leaning forward, applying direct pressure, using ice or nasal packing. Next is sinusitis. It's basically inflamed sinuses. Symptoms depend on which sinus is affected. Maxillary equals cheek pain. Frontal equals forehead. Treatment includes warm packs, fluids, nasal steroids like Flonase, and antibiotics only if it doesn't resolve in 7+ days. Then we have obstructive sleep apnea, episodes where breathing stops during sleep. Risk factors: male gender, obesity, smoking. Treatment includes CPAP therapy, weight loss, avoiding back sleeping and sedatives. Nursing tip: untreated sleep apnea increases risk for heart disease, stroke, and diabetes. Respiratory viruses, flu, COVID, and other respiratory viruses need isolation precautions, rest, and fluids. Use antivirals like Tamiflu within 48 hours of symptoms, and never give aspirin to kids. We're avoiding Raynaud's syndrome. Lower respiratory disorders. Let's start with pneumonia. It's inflammation in the lungs that clogs up the alveoli with fluid. Symptoms: fever, cough with rusty or yellow sputum, dyspnea, crackles, and sometimes chest pain. Nursing tip: always get the sputum culture before giving antibiotics. Asthma versus COPD. Asthma is reversible. COPD is not. Asthma has wheezing, tight chest, cough. Triggers like allergens, cold air, stress. Treatment: bronchodilators, steroids, and avoiding triggers. COPD includes chronic bronchitis and emphysema. Think barrel chest, chronic cough, and low SPO. Keep oxygen at 88 to 92%. Too much can decrease their drive to breathe. Tuberculosis, caused by Mycobacterium tuberculosis. Symptoms: persistent cough, night sweats, weight loss, hemoptysis. It's airborne, so patients need N95 masks and negative pressure rooms. Treatment: the right drugs: rifampin, isoniazid, pyrazinamide, ethambutol. It takes 6 to 9 months, so medication adherence is a must. Pneumothorax and pleural effusion. Pneumothorax equals air in the chest, causing lung collapse. Pleural effusion equals fluid in the pleural space. Look for uneven chest expansion, diminished or absent breath sounds, chest pain. Intention pneumothorax. Watch for tracheal deviation. Treatment: chest tube to remove air or fluid, respiratory failure, and NADS. Acute respiratory failure means the lungs can't get enough oxygen or clear CO. Signs: confusion, restlessness, cyanosis, ABGs, POW, 50 and POCOs greater than 50. Get help immediately. ARDS is severe lung injury, often from sepsis or trauma, leading to non-cardiogenic pulmonary edema. You'll see hypoxia, crackles, whiteout chest X-ray. Treatment requires IQ care, mechanical ventilation, and sometimes prone positioning. Lung cancer and cystic fibrosis. Lung cancer symptoms usually show up late, like chronic cough, hemoptysis, and weight loss. Cystic fibrosis causes thick mucus in the lungs and pancreas. Patients need enzymes with meals, chest physiotherapy, high-calorie diet, and eventually may need transplant. That wraps up our crash course on respiratory nursing, from assessment to acute care. Remember, every breath your patient takes could depend on your skill and knowledge, so breathe deep, keep learning, and keep showing up for your patients. Thanks for listening, and I'll see you in the next lesson.